Hello everyone, I'm Catherine Bakewell. I'm reporting from ACR 2024. I'm standing next to my colleague and friend Lihi Eder, and we're going to talk to you a little bit about updates from this ACR on ultrasound in psoriatic arthritis. There are two sessions that I want to highlight today. The first one was session, and I've got the number written down, 16S06. This is the ACR proposed guidance statements for the use of musculoskeletal ultrasound in both rheumatoid and psoriatic arthritis. I would like to refer you actually to an interview with Anthony Chen that was done earlier today, but the bottom line is that the ACR combined with US Sonar is trying to put out everyday practical application statements for the clinician for the use of musculoskeletal ultrasound in both rheumatoid and psoriatic arthritis. How do we define these diseases diagnostically by ultrasound? How do we look at treatment response, remission rates, and how do we make this applicable in day-to-day clinical practice? I also have next to me Dr. Lihi Eder, who presented an update on Duet, a diagnostic ultrasound enthesitis tool, a combined international collaboration with GRAPPA, the Group for Research and Assessment for Psoriasis and Psoriatic Arthritis, and I'm hoping she can tell us a little bit about what you taught us today.
Okay, so Duet is really aimed to develop a new diagnostic tool for enthesitis, sonographic enthesitis. We know that it's very hard to accurately diagnose enthesitis in PsA, and we hope that this new tool will help us with early diagnosis of the disease. So this was really an international collaboration. We spent a lot of time training people, and there was also a unique component of central scoring, which is not usually done in ultrasound studies. We presented today the preliminary analysis, and what we found is that, first of all, some of the elementary lesions are not unique to PsA. I think this is known to people that are doing ultrasound. Things like thickening, hypoechogenicity, and tesophytes can be found in older individuals, and so this is one thing to keep in mind. Secondly, lesions that seem to be more specific, like power Doppler erosions, were not very common in patients with early disease, but when they do appear, they seem to be very discriminative.
Yes.
The third important message is that the ability to discriminate enthesitis by ultrasound between PsA and non-PsA patients seem to be dependent on the enthesial site. So there are some sites like the patellar tendon insertions, the Achilles tendon, and the triceps tendon that seem to be more discriminative than areas like the plantar fascia or the supraspinatus insertion. So putting all of this together, these helps us understand or think about the next steps, which are aimed to narrow down the number of sites that we need to scan, to weight some of the elementary lesions accordingly, so those that are more discriminative will get higher weight. And ultimately, we hope to create total scoring system, total score, that hopefully will help us make diagnosis early, think about prevention studies, and so on.
That's fantastic. I cannot wait for those results. I think this is fabulous work that you are doing and have done already, and I know we're eagerly awaiting the final results. Thank you so much for chatting with us today.